Hi, I'm Dr. Mark Shelley. I'm the clinic director here at Olympic Spine and Sports Therapy. I'd like to thank you for taking time to watch this video. Most probably, if you're watching this, it means that either you or someone you know is suffering from chronic pain, either in their back or their neck. What I'm going to cover in this video are common causes for pain. We're going to go through how you accurately diagnose a condition, evaluation procedures that are used. We're going to go through some of the different treatment methods that are commonly used as well, and really focus in particular on the unique procedures that we use here, which is a combination of both advanced new treatment technologies, combining decades of hands-on clinical experience, and using a combination of different treatment modalities. What I'd like to start with then is some of the common causes for chronic pain. Most commonly, disc herniations, spinal stenosis, arthritis or facet syndromes, disc degeneration, spondylolisthesis, or failed spinal surgeries. One thing I want you to know right from the start is we've seen results with every one of these conditions. Patients getting free from their pain and getting back to their lives again. Many of them were told that they had to either have surgery, they had to live with their pain, which really isn't living, it's just suffering with it. Many of them had given up different aspects of their life, activities. They couldn't hike, they couldn't play tennis, weren't able to play with their grandchildren or even their own children. Their work was impaired. Their ability to enjoy their quality of life was impaired. We've seen results with every one of those types of cases. Now, am I saying that the treatments we use are cure-alls? No, they're not. And that's why it's very important that we're using good screening procedures to determine who's a candidate and who's not for treatment. The treatments that we use are FDA approved, they're safe, they're pain-free, they're non-surgical. Before I go into the details though, I think you deserve to have some background about my credentials. I graduated from Sherman College of Chiropractic in 1983, summa cum laude, class valedictorian. I have over 25 years of practice experience here in Edmonds. I've been trained in 9 different adjusting techniques. I have certification in chiropractic biophysics, and I founded Olympic Spine and Sports Therapy in 2000. It was the first multidisciplinary practice in Washington State to combine non-surgical decompression, chiropractic biophysics, cold laser, physical therapy, massage therapy, and functional neurology. So I'd like to explain how Olympic Spine and Sports Therapy came about. My idea of fun is putting myself in bodily harm, in danger. I enjoy skiing and snowboarding and mountain biking, and as a result of that, I've experienced fractures, dislocations, sprains, strains, disc herniations. I like to say that my pain has been for my patient's gain. Everything I've learned how to heal myself, I've been able to apply that here in the practice for Olympic Spine. What I want to do now is transition and get focused on how we get an accurate diagnosis, how we determine if a person is a good candidate for treatment. The first is disease processes such as cancer or fractures. Most probably, if you are watching this video, you have chronic pain, you have been through all kinds of testing. I call it the medical merry-go-round. The greatest probability is if there was some disease process, it would have been detected and you would have been sent to the appropriate specialist. Nevertheless, we are going to look very carefully and make sure nothing has been missed. We will leave no stone unturned. The second and really most common cause is mechanical pain. That's abnormal alignment and motion. And the third is compressive lesions. So what causes mechanical pain? This comes from both abnormal alignment and abnormal motion in the spine. This produces what I call the downward spiral of spinal degeneration. We start with the abnormal alignment and abnormal motion. This causes stress and strain to the muscles, the ligaments, and the joints, which in turn causes pain, inflammation, and degeneration, which in turn causes more abnormal alignment and motion, a self-perpetuating cycle. So that vicious cycle of degeneration causes postural decay. This is what it looks like on the outside. We start with Peter here with his perfect posture, and as his head moves forward, his mid-back starts to arch. It moves forward further, and then ultimately it leaves Peter hunched over, locked into a flex position to the extent that he's no longer able to even straighten up. So what you're looking at here is a side view x-ray of a person's neck. They're facing to the right side, so their nose is to the right on this film. The back of their head is to the left. You'll notice that their head is balanced over their shoulder, and there's a beautiful natural arching forward curve in their spine. In between the bones, those dark spaces, that's where the discs are. So this is normal, this is ideal. What we're going to do now is I'm going to time-lapse this video so you actually see what happens over time with abnormal alignment and abnormal motion. And what you'll see is the natural forward curve now is going away, the spine is straightening, so you're losing the shock absorbing ability of the curve. Now the curve is literally reversing, it's starting to go backwards. That's putting more stress on the joints. I'll draw your attention now to the mid-lower section of the spine. What you're going to see is those darker spaces where the discs are, you're going to see those spaces getting smaller. That's degeneration of the disc. The disc is deteriorating, it's rotting away. In the lowest sections, actually the discs are completely gone now. There's fusion that's taken place, and there's infiltration of calcium. There's arthritic development. That's all of the additional white that you see on the film. So that process of degeneration then can lead to compression. So let's take a look at the discs. What you're looking at here, we have two vertebrae, the disc in between. Here's a disc on top. The anatomy of the disc is such that the outer layers of the disc are called the annular fibers, very tough fibrous material. The inner portion is called the nucleus, and well, for a young healthy disc, it's a soft gelatinous material. When we have repeated strain, normally again due to abnormal alignment, abnormal motion, that will cause the disc to wear. If that's allowed to progress, those outer bands, the annular fibers of the disc, they start to break down. The inner portion, that nucleus, then can actually start to migrate, and this creates a disc protrusion. We're going to talk at length about how that's treated. If the condition is allowed to progress, the final stage is when the joint actually completely fuses together. At this point, of course, well, there's nothing that can be done conservatively, and typically there's bony compression to the nerve. Let's come back to the disc for a moment. Often there's a lot of confusion over the terminology. People have been told that they have a disc herniation, they've heard about protrusions, prolapses, extrusions. Those are really all synonyms for pretty much the same thing, where the disc itself is creating pressure into the nerve. Other areas of confusion with terminology, you hear terms like spondylolisthesis. Spondylolisthesis is a slippage of the vertebra. You hear terms like spondylosis. That means arthritis that's affecting the vertebra. You hear terms like facet arthrosis, and you'll see these on your MRI or CT reports. And that means arthritic development in the back of the spine. In general, it's very helpful to delineate between two categories here. We have hard tissue problems, which is bone, and we have soft tissue problems, which is going to be the disc or it's going to be ligaments. In general, if we're dealing with soft tissue problems, well, that's much better news. The prognosis is much better. It's much more likely that we're going to be able to help with conservative procedures. When we have bony compression, very often the only alternative then is surgical decompression. And again, we'll talk about these at more length. Let's shift gears and talk a little bit about diagnostic imaging and how it can help determine if we're dealing with hard tissue or soft tissue problems. So the first picture that you're looking at in the upper left-hand corner, that's an x-ray of a low back. And actually this person has that word you heard me say before that everyone has such a hard time pronouncing, which is spondylolisthesis, the slippage of the vertebra. So the x-ray is very good in detecting problems with bone, such as pathologies, if there's any disease process, also if there's a problem with alignment or with motion. In the lower right-hand corner, what you're looking at is a picture of an MRI. And the advantage with MRI is we can visualize soft tissue. In this case, the very bottom disc, there's actually a protrusion. The disc is bulging backwards into the spinal cord. So MRI allows us to see the disc, it allows us to see nerves, ligaments, and muscles. So as advantageous as the advanced diagnostic procedures are, it's not a substitute for still having a thorough history, doing a detailed physical examination. Combining all of this information allows us to arrive at an accurate diagnosis. And of course, that's what allows us to determine the appropriate treatment options. Let's take a look at those. First, we're going to look at at what often is called simple mechanical. With a mechanical problem, again, we're talking about abnormal alignment, abnormal motion. Treatments for that, when we're dealing with muscular problems, massage therapy can be an excellent tool to be able to release contractured muscles. Weakness and imbalances in muscles are best served with physical therapy. Joint problems, alignment problems are going to best be corrected with chiropractic care. As I was saying, the mechanical pain is often termed simple mechanical back pain. If you're experiencing that, it may not seem very simple to you. The solutions, though, very often require only one type of treatment, maybe just physical therapy or adjustments, and the treatment duration may be very short. Odds are, though, if you're experiencing chronic pain, it's been around for years and years, it's a more complex condition, and it's led to then a compressive lesion, which is what we're going to talk about next. With a compressive lesion, the only way that you're going to correct that is to create more room for the nerve structures that are being compressed. The only way you can create more room is actually to decompress. And that leaves us with options of either surgical decompression, going in surgically, removing tissue. There are a couple of common procedures that are used. The first is discectomy. With the discectomy, they're surgically removing part of the protruding disc that's causing compression to the nerve. The next is a laminectomy. In this procedure, they're actually cutting away bone to create more space. And if there's a condition that's known as instability, in other words, if the spine moves excessively, sometimes they'll perform the discectomy and laminectomy to decompress, and then they'll fuse the joint so that that instability is resolved. The next category is non-surgical decompression. And I'm glad to say that we have this as an alternative to the surgical procedures. Predominantly, again, this is going to be for soft tissue compression to the nerves. And it involves non-invasive multimodal treatment. I know that's some big words. We're going to go through and break that down for you, though. With a compressive lesion, then we have to look at some different treatment options. The first, surgical procedures. Let's talk about those. When there's protrusion of the disc, the way that's dealt with is called discectomy. So they go in surgically and are going to cut away the portion of the disc that's protruding, causing the compression into the nerve. The next procedure is called a laminectomy. With a laminectomy, they're going to go in and cut away bone that's surrounding where the nerve is. Also, the objective being to reduce that pressure into the nerve. If there's a condition that's known as instability, if the joint moves excessively, then they'll often perform the procedure of discectomy, laminectomy, and they'll go in and fuse the joint together so that instability is resolved as well. I'm glad to say that for soft tissue problems, we have an alternative now in non-surgical decompression. With non-surgical decompression, what we're doing is using a sophisticated computer-controlled machine that gently stretches the spine, creates a vacuum in the disc, and sucks the protrusion back in. That relieves that pressure and irritation into the nerve without having to go in surgically and use invasive procedures. Let me give you some background on non-surgical decompression. Non-surgical decompression was invented by Dr. Alan Dyer. He's an MD, PhD, and in 1991 he created what's called the VAX-D table. This first picture you're looking at on the left side shows an MRI with a protrusion of the bottom disc. Again, the lower right-hand corner shows that same patient after completion of non-surgical decompression treatment, and the disc protrusion is resolved. The next person I want to bring your attention to is C. Norman Shealy, also an MD, PhD. He's an instructor at Duke University. He created what's called the DRS system. That stands for decompression, reduction, and stabilization. It's his treatment procedures that we originally started with and have built off of. So non-surgical spinal decompression is safe, it's pain-free. Most patients actually fall asleep when they're on the machine. You have complete control over it. If there's any discomfort at any time, you can shut the machine off. Again, as I said, it's FDA approved, has a very high success rate for soft tissue conditions. Again, that's meaning disc, ligament, facet, or inflammation problems. The research shows over an 80% success rate, as a matter of fact. Let's take a look at the different phases of care. First, we have decompression and reduction of inflammation. Next is biophysics correction, and third is stabilization. Let's go over the first phase, the decompression and reduction of inflammation process. The major component here, of course, is non-surgical spinal decompression, the use of the machine. When a patient comes off of their decompression session, then we have to stabilize the area. So if they're getting decompression for their neck, we're going to use a cervical collar. And if it's for their low back, we use what's called a disc distractor belt. And this isn't just your typical neoprene type of belt. It actually is more like a corset that a woman would wear to pull her waist in. It's very powerful, and the objective is to immobilize the low back and protect you, and to actually protract the benefit of the decompression process. So the procedure is that you wear that for 2 hours following the decompression session. In addition to decompression, in that initial phase, working to reduce inflammation, massage therapy again is very helpful to reduce contracted and inflamed muscles. We also use a procedure that's called cold laser. Cold laser has been in use since the 1960s in Europe. It's taken till, I believe, 2004 to get FDA approval here. Cold laser is actually just focused light, and the way it works is very similar to the way a plant uses sunlight. So the chlorophylls in a plant will take sunlight energy and convert that into energy that it uses for growth. In our body, we have what are called mitochondria in our cells. The mitochondria function to produce energy that run all of our cellular processes. This particular wavelength, which happens to be 810 nanometers, that wavelength of light is absorbed by the mitochondria, so they're able to produce more energy so they can repair, we can heal faster. Many research studies done on cold laser and show on average about 40 to 50% faster healing rate for soft tissue, meaning muscles and ligaments. So after a decompression session, a patient will receive cold laser therapy, then they put their brace on. The next treatment is low or non-force chiropractic adjustments. Now, many people are scared at the thought of having adjustments, as particularly if they have a serious back condition. Key here is we're talking about low or non-force adjusting procedures. I want you to understand not all of our patients receive adjustments. Very importantly, many of our patients with severe back conditions, traditional adjusting procedures are inappropriate for them. Now, in contrast to traditional forceful adjustment procedures, non-force, low-force methods can be extremely effective. One of the instruments we use is called the activator. This is spring activated, and it's a very light impulse instrument that produces a force that can be used for adjustment. We can use this for elderly patients. We can even use it for children. Very gentle. Matter of fact, I've adjusted children with this that come in sleeping, and they keep sleeping. Similar version, but motorized, is called the arthrostim. This is a motorized unit. Matter of fact, many patients, well, they like us to keep using the arthrostim. They want to use more because it feels like massage to them. So these are a couple of the non-force gentle methods that are used that allow us to get the benefits of adjustment of reducing pain, reducing muscle spasm, reducing inflammation without having to use forceful procedures. The last point in our decompression and reduction of inflammation phase is clinical nutrition. Most all of our patients that are in the DISC program, we're using an herbal anti-inflammatory, so we're reducing inflammation without having to rely on pharmacological means, and using also what's called glutathione with SOD. And this is a topical ointment that a patient applies to the area and allows us to get glutathione, which is the number one antioxidant in our body. It's the most powerful antioxidant we have, directly into the source to reduce free radicals and again accelerate healing. The next phase we want to move into then is biophysics correction. Let me just review what we've accomplished at this point. Using all the different tools in this first phase, we've reduced inflammation, we've reduced pressure. At this point, a patient is feeling better. Now we can turn our attention to working on correcting the actual underlying cause of the problem, that abnormal alignment and abnormal motion. The picture that you're seeing is an x-ray of a patient's hips. You can see actually on the left side he's had a hip replacement surgery. Let me give you a little bit of background. This patient, Steve, came to us trying to avoid his third spine surgery. That's why I said third. He had a previous surgery on his back and a previous surgery on his neck, and they were telling him he needed to have another surgery on his low back. He came to us looking to see if we could help without using invasive procedures. I'm glad to say that we were. Steve got great results with his decompression process. When we found that, when we did our evaluation, looking at this x-ray, that he had a congenitally short, in other words, just grew that way, short right leg, about 1.5 inches shorter on his right side than his left. So part of his treatment procedure using biophysics was to work and balance his pelvis. So we used the procedures you see listed here, mirror image exercises to retrain muscles. We did postural adjustments for nerve and joint function. We did posture corrective traction to reshape ligaments. In addition to that, we also used lifts and inserts to work to balance his pelvis to bring it back to normal height. This brings another really good point. With Steve, after probably 3 or 4 weeks of treatment, his symptoms were greatly reduced. If we had discontinued his treatment at that point in time, what do you suppose would happen? Well, he'd feel fine for a while, but ultimately, with that imbalance in his pelvis, it's virtually a guarantee that his symptoms would come back. So our objective, of course, is not just short-term Band-Aid for a problem, but is to actually correct the underlying cause. The reduction of inflammation, decompression, then we have to actually correct the mechanics of the problem. In the next phase, we're going to talk about stabilization. The goal is to get you to where you're free from pain, you're able to do life the way you want to, and we've trained you up what you need to do, we've made the changes so you can stay in that place. Steve's particular case, he was a great success, not just because of decompression, because we actually found the underlying cause and we corrected that as well. So in our last stage, stabilization, the primary components are physical therapy and functional neurology. Physical therapy, most all of you are familiar with, and many of the procedures we use would be considered traditional physical therapy procedures. We're very blessed to have a head of our physical therapy department that has over 30 years of experience. Procedures here, of course, are working to correct muscle imbalances and improve strength and endurance. In addition to physical therapy, we also use functional neurology. Now, the objective of functional neurology is to restore neurologic regulation for stability. One of the types of treatments that we use with functional neurology is called supplemented oxygen therapy. So our brain, while it's only about 8% of our body mass, consumes 20% of the entire body's oxygen. The most vital area when it comes to oxygen utilization is this small portion in the back of the brain called the cerebellum. The cells of the cerebellum are the most oxygen dependent of any in the body. The cerebellum is controls many different functions. Relative to what we're talking about in treatment for chronic pain, though, one of the most important features is that the cerebellum controls the state of contraction of what's called the intrinsic muscles in the spine. So those are the muscles that give stability to the spine, that give us our strength. So if your cerebellum doesn't work well, your back muscles won't either. Functional neurology, of which again the supplemented oxygen is just one of the different treatments, it's been key in helping some of our toughest patients that haven't found relief with any other treatment procedures, helping them get their free from pain and get their quality of life back. So that's the last of our 3 phases of care. And just to review, the first phase is decompression and reduction of inflammation, the second is biophysics correction, and the third is the stabilization phase. I want to thank you for taking time to watch the video. I know we've covered a lot of information. There's a lot to cover. As you probably can tell, I could take hours on some of these topics to give you details. Which reminds me, while I think of it, any areas you have specific interest in, go onto our website and you'll find a lot more information on those specific topics. Another point I definitely want to make is not all patients get all of the treatment. The specific treatment procedures that are used, those are tailored to each individual. They need to, matter of fact, there aren't any 2 patients in our practice that get the same treatment. That needs to be tailored individually to you. My job really is to be a detective, to find what the underlying cause of the problem is, and then orchestrate the different treatment procedures that are necessary for you to get out of pain, to get your life back, to be able to do what you need to and you want to. There's really nothing that's more rewarding than helping people get back to their lives again. If you'd like to find out if we can help you, just call and schedule an appointment for a consultation. Wouldn't it be great to be able to get better and do more without using drugs or surgery? I want to thank you again for taking the time to get this information. I'm Dr. Mark Shelley with Olympic Spine and Sports Therapy. I look forward to meeting you and love to help you get better.